Hi, everybody. Paul here, just doing a sound check. Anyone out there?
Paul, this is Harish. I can hear you.
Great.
Paul, we
Hi,
can
Harish.
hear you. We can hear you loud and clear. Thank you. Harish, we can
Thank
hear
you.
you also loud and clear. Thank you.
Thank you.
3:30 and let's get started. Can I have everybody come inside the room, please? I'm looking forward to have you all for the penultimate session. After this, we have only the wrap-up. We've looked at finance, we've looked at governance, we've looked at digital health, we've looked at digitization, and over the last 2 days, we've been through more than 7 systems in healthcare, health systems resilience. Ensuring the supply of goods and technologies for building a resilient health systems is going to be our session. Do you remember how all the magazines had lack of oxygen supply, lack of this supply, lack of that supply? Where are the kits going to be? Where is the PPEs coming from? How do we actually make sure that we have enough and more for 1 billion plus people and also share globally? All this happens because people do ensure that there is a last mile connectivity that we need to have as part of the supply of health goods and the technologies for health systems resilience. I have Mr. Maulik Chokshi, Deputy Director Technical at Access Health International, who will moderate this session. Inviting Ms. Deepanwita Chowdhury, Chairperson and CEO of IKP Knowledge Park. Deepanwita developed the first life sciences research park in India in Hyderabad. She pioneered a hardware product incubator and a maker space, IKP Eden, in Bangalore, and works with Indian and global partners to support over 1,400 innovation projects and early startups. She authored the India chapter for the Global Innovation Index report in 2020 and has received the FICCI Flow Influential Women Award in 2021 for her outstanding contribution to the innovation of the ecosystem. In 2018, she was awarded the Top Woman Achiever of the Year, and in 2017, Asia by the Asia One Business magazine, and Women of the Decade in Life Sciences and Innovation by the Women's Economic Forum. Deepanwita took over as chairman of IKP in November of 2015 and is also a member of several national level committees. Deepanwita, I have seen you young and grow into this role, and you have made a difference to the way IKP and the Knowledge Park looks. Pleasure to have you here. Mr. Harish Iyer, who should have joined us in person, but for other reasons, has to join us remotely, is the Deputy Director Digital and Health Innovations at the Bill and Melinda Gates Foundation. Harish's interest in the role of innovation, science, and technology in improving public health and equitable economic development. He's a strategic partner between the Indian researchers, global partners, and the Foundation's team in the critical R&D work, including in vaccine-preventable diseases, new approaches to treating neglected diseases, life science partnerships for public health, digital health innovations for all, and reducing the digital divide. Prior to his role in the Foundation, Harish was the CEO of Shanta Biotech from 2011 to 2015. He has also worked with various R&D roles in several biotech companies, including as the head of R&D at Biocon, and in various technical roles at Biogen, IDEC, and Green Tech in the US. Thank you, Harish, for joining us remotely. I know you have a challenge and a constant worry on time, but it's always a privilege to speak to you. Harish, I hope you're there.
Yes, Uma, thank you. Thank you so much for the introduction.
Yeah. Mr. Neeraj Jain, the Country Director of PATH India, Director, PATH South Asia. Neeraj leads the South Asia region at PATH, has over 30 years of experience in leadership in strengthening organizations. His strengths lie in business development, setting up new ventures, organizational development, ecosystem development, and strategic leadership for change management in organizations across Asia and Europe. With his leaders, PATH South Asia Hub has tripled its annual portfolio and quadrupled its head count. What a privilege. And has expanded its presence into 4 new countries and 23 Indian states. Neeraj's current focus at PATH is to partner with governments and partners for health system strengthening, especially primary healthcare, and mobilize PATH's technology assistance on-ground operations for the same. Prior to joining PATH, Neeraj led Border Aid India as its chief executive. Privileged to have you here, Neeraj. I next have the privilege of calling upon Ms. Nitika Garg, the Director of Research and Policy Advocacy Organization of Pharmaceutical Producers of India, OPPI. With a decade and a half of experience, Nitika leads the research function at OPPI. She is responsible for providing an analytical support to advocacy campaigns of the OPPI, a pharmaceutical industry, and assists in the strengthening of the OPPI's position as a knowledge partner to member companies on the pharma policy. Most recently, she was working with the Bristol Myers Squibb as Associate Director, Market Research. She worked with BMS for 6 years across multiple therapy areas and projects spanning market research to product launches strategies, business strategies, access strategies, as well as commercial excellence. Prior to BMS, Nitika worked along the leading Indian pharmaceutical companies like Glenmark and Biocon. I now have Professor Paul Lalwani, again a remote. He's the founder and director of Empower School of Health. Professor Lalwani and the Center for Digital Learning, CDL, and the Center for Leadership Development. He has more than 25 years of experience in capacity building, procurement, supply chain, access to medicines, and technology transfer. The former head of the Global Funds Department for Procurement and Supply Chain Management, advisor to Gates Foundation, WHO, World Bank, and various ministries of health. His area of expertise includes health advocacy, business development, capacity building, strategic planning, policy development, national and international partnerships. Also privileged to be joined remotely is Dr. Ronald T. Piervincenzi, the CEO of United States Pharmacopeia. Ronald, a PhD, began his tenure as the CEO of the USP in February 2014. Ronald provides strategic leadership to the USP's global staff, over 1,300 across several regions. His transformative vision has launched key USP initiatives in bringing quality across the healthcare spectrum under his leadership. USP has modernized its operation, launched innovative new science, including the areas of digital medicine, cutting-edge manufacturing technologies, and advanced biologics. Ron, brings more than 25 years of industry experience across pharmaceutical sciences, research, and business strategy. Before joining the USP, Ronald served as Vice President of Developmental Sciences with Biogen and was a partner and leader in McKinsey & Company's global pharmaceutical medical products practice for over 12 years. What an illustrious panel, and I hand it over to you now, Maulik, to take it forward. Thank you so much.
Thank you very much. Thank you very much, Uma. I think that's also a daunting task to be present amongst the stellar people, and I'm sure that I'm going to learn more than I knew before. But in order to set up the stage, I think so I have the responsibility. And when we started conceptualizing annual conclave, as we went through various segments on which we are learning since morning, one of the most crucial factor for health system resilience that emerged was access to commodities after healthcare financing along with governance. So governance, healthcare financing, and access to commodities were principal drivers, and not kind of saying that others are not important, but they are drivers which can really act as control knobs to make health system resilient. And when I say commodities, we kind of understand commodities as access to medicines, access to diagnostics, access to vaccines. So these are the bouquet that we refer to when we say commodities. And what we saw in during COVID pandemic, I think so. If we start look at global kind of health expenditure, expenditure on commodities is the second most spent line item. After human resources, maximum amount of money that health system spends is on commodities. So having efficiency gains, making commodities accessible to people is also important to strengthen health system response. And when COVID struck, I think so the systems were already facing challenges in access to commodities for various reasons, right? Starting from market access issue to pricing issue to supply chain issue. And COVID just exacerbated those issues. I think so. And those issues got further kind of amplified with the mere fact that a lot of vaccines or diagnostics required for detection for COVID and for prevention or kind of healthy individuals in form of vaccine were innovations. And when people start talking about innovation, access to innovations, I think so there is a huge kind of gap of access to innovative technologies in high-income countries versus low and middle-income countries. And when we started thinking about resilience, I think so access to those innovative products is one of the core components to make health system resilient. So how faster can you get this innovative product across low middle-income countries as well as high-income countries? So that was one aspect. Not taking away the fact that, and since we have spoken in the morning also, that resilient health system is not only shock dependent, but your system should be strong enough to kind of keep providing basic minimal care. And that goes beyond the scope of innovative molecules to generic molecules and off-patented molecules. But what we intend to focus in terms of resilient health system today is how we can foster ecosystem which can enhance faster availability of affordable innovative molecules in your health system. And with that perspective, I think so the stellar panel is lined that way. And we start with Harish asking, and Harish, as Uma described, has been in forefront on this technological innovation aspect. So if I may come to you, Harish, I think so, what is the role that global health institution can play along in interface with pharmaceutical industries to get these innovative products to low and middle income countries in time of emergency and in other situations as well? Harish, thank you.
Yeah, thank you, Maulik. Thank you so much for inviting me. I do feel quite bad that I'm not there in person because I was listening to the earlier session panel and it was so fantastic to see the energy. So, but anyway, but I couldn't help it. I was planning to be there, but I could not be there. So apologies for that. I think I will sort of highlight a little bit how the Gates Foundation thinks about it. I will be giving some of the context specific to India, but some of it can be generalizable, some of it is harder to generalize. Obviously, the foundation itself has a history of trying to provide access to medicines that the science of the North creates, right? So, for example, the very beginning of the Gates Foundation was about access to a vaccine called rotavirus vaccine. Bill and Melinda were very concerned about diarrheal deaths that were completely preventable due to access to a particular vaccine that was widely available actually in the rich countries, but not available at all, or certainly not affordable in the poor countries, right? So there is the whole seed of the genesis of the way the foundation has worked is to see how can we make sure access is there as quickly as possible. And if you look at the time at which, let's say, a rotavirus vaccine was introduced in a wealthy country and a poor country, you will see the differences was less than maybe 6 months, or barely 6 months, I would say. And I'm talking about India in particular. For Rota, it was many, many, many years, and this gap is slowly sort of brought down over time. And I think the idea here would be that there are many factors here. Obviously, there is active funding needed to catalyze, technology transfer. That's the starting point. There's certainly very great deal of importance that what the national market is. Obviously, India is a special case. It's a large country, large domestic market. So an approval in India does give you, a large customer base. But obviously, smaller countries will have to think about how they can band together to make sure they can come together and access innovations more quickly. Very, very important aspect of it. I think national policies are very important in terms of how do you set up manufacturing capacity, how do you set up R&D, and what are the incentives, right? What are the incentives? So are you willing to, and how would you import and use ideas, use products and technology to drive healthcare innovation so that you're prepared for an emergency? So very important. The whole discussion around localization, do you need to manufacture it locally or not, is a complicated question to answer always. Small countries will have a harder time manufacturing locally. Large countries like India or China or the United States will be able to perhaps do it better. European Union would have to think about this as well. A lot of this has to have upfront interactions between the global North and the global South. We have to be clear that the global North is certainly quite advanced in science. A lot of the products that come out let's take the pandemic, for example, right? PCR or antigen-based assays or new drugs for antivirals were all sort of products of the North, if you will, technologies and science that comes from the North. How do you make sure that the science is reproduced in the global South? How does the global South catch up on some of these things is going to be very, very important to build resilience, because of course there is political compulsions that drive which product goes where and which technology goes where. And then, I would also very quickly add regulatory harmonization is a very important aspect of all this. How do you make sure that once a product is approved, it gets taken up as quickly as possible around the world? And it's obviously linked to the financial aspects of it, availability, manufacturing and all that. But how do you make sure that a result, a major clinical result, can either be quickly reproduced or bridged in the local in the local context? Again, I think I would say that organizations such as the Gates Foundation, I can speak mostly to Gates, I will let others talk about other organizations, have tried very hard to make sure that technology, science, and low-cost access is available as quickly as possible. You have things like the medicines patent pool that could be one approach to make sure this technology is more widely available and quick transfers occur and the capabilities are built locally. I can talk for a long time on this, but maybe I will stop now. I don't know how much time I have to speak, but I will stop now, Maulik. Thank you.
So, Harish, I have a follow-up question on that. You did started mentioning about once a product is available, right? And the examples of transferring technology once the products are available. But what kind of role does multilateral organization play in fostering innovations, right? A vaccine development, right? From kind of phase 1 clinical trials. What kind of role does organization play in global architectural context?
Yeah, I think that's really a tough question to ask, right? I mean, over time, So for example, diseases that are relevant to the South, for example, let's not talk about HIV. HIV is, let's say, relevant globally, but let's say a neglected tropical disease, for example, that's relevant to the South. It's neglected because to some extent, neither the North nor the South has spent enough time thinking about it. So there we need to create incentives for innovation where the disease is located geographically in the South. How do we create the regulatory framework? How do we create the funding framework? How do you bring scientists? How do you train scientists? And there may be things like training required in many of these things. How do you do controlled human infection studies, for example? Or how do you have the right animal models, right? Some of this has already been developed. How do we work together to develop animal models? How do we work together to develop molecular level assays to understand? How do we understand clinical endpoints? What are appropriate endpoints? I think some of this, there is a great deal of collaboration that can be very helpful. The field of research should certainly be in the global South. It should be an equitable field of research where researchers from the South and the North, because North again has a lot of the expertise, are on an equal footing. How can they collaborate? How can we strengthen laboratory capacity? If you look at what India is doing, and I can speak more to what India is doing, right? India has taken the outcomes of the pandemic very seriously. We were just recently meeting, for example, the principal scientific advisor, and we're going to thinking about launching this National One Health program and National One Health Institute, right? How do we, and our role would be, how can we collaborate on it? How do we understand the surveillance system? How would the surveillance system look for zoonotic diseases? Something that was very relevant for COVID, right? I mean, you have a pathogen probably came from a bat. Same thing true for Nipah virus. There's a Nipah virus outbreak ongoing right now in Bangladesh. How do we make sure you understand human and animal contacts? How do you look at equally important just pandemics of animals themselves, right? I mean, it's not, animals are an important economic resource. So they're all interlinked together. I mean, human beings survive, get incomes from plants and animals. You need to understand the same thing for plants and animals as well. So I think some of this basic science capabilities need to be built in the South, will be continued to be built. Different countries, ideally having regional networks, people can learn from each other. In the Indian context, it might be the CRO network or some other network that would want to be strengthened. And then again, use support from the North. Ideally, the North should support it. They should not be looking just inwardly. They should know that there are no borders for viruses and bacteria. They have to be supportive. So it's going to require some political discussions, some financial discussions, scientific discussions as part of strengthening the overall network.
Thank you very much, Harish. I'll come back to you, but during your remarks, you referred about a regulatory system, and I think so harmonization of regulatory system, and we are privileged to have Ron from USP out here. So Ron, I think so the role regulatory system play during normal times is well appreciated, but when emergency strikes like COVID pandemic, I think so the duration that we have to respond goes down substantially. In that case, how do we build the capacity of regulatory system to get faster approval of products? What kind of approaches can help them? That's number one. And secondly, I think so when we start talking about medicine and quality of medicine, we generally get stuck to regulation and quality in terms of market authorization. And there is not a lot of conversation happening, regulation that is required downstream to ensure quality of medicine. So can you, from your international experience, can you throw some light on based on the work that USP is doing globally? Ron?
Yeah, thank you, Maulik. I appreciate it. And I really appreciate the chance to participate from the somewhat dark Washington, D.C. at the moment. I want to also say a special thanks to Access Health colleague of yours, Dr. Krishna Reddy, for joining the USP's board a couple of years ago for a 5-year term. It's a pleasure to work with him, and I know he's in attendance. So the broader question you share about the regulatory, it's a 3-part. So I'll connect the 3 that seem different. One is the ideas of essentially collaboration, and one way to think of that is harmonization and convergence of methodologies. Another is capacity building of regulators, which is something different. And a third being the importance of quality as an underpinning of this acceptance and how that can support access to quality medicines. And I'll draw the three together. I liked how you worded that question. I kind of first start with, in crises, are moments to, I guess you'd say, try to turn them as much as you can into an opportunity. And in particular, when it comes to system development, there's often more help and attention and resources available in a crisis, which you can use to help build the system. So like specific examples, during the pandemic, there were individual therapeutics, clearly the vaccines, but I think we've talked about that even more. So, but outside the vaccines, even in therapeutics like remdesivir, and there was interest and need to conduct a tech transfer from innovators to producers who can create high volume, lower cost products. And that partnership is very specific. You're solving a specific challenge on a specific critical, but specific medicine, and perhaps even in a couple of specific countries. So how do you turn that into a system that feels like a big difference? And I think it's not as difficult as it seems when you are focusing at the regulatory center, as you described, meaning that the production of that technology transfer certainly involves a manufacturer, clearly, and that manufacturer, hopefully the capability built in the transfer of that particular technology could then be used for subsequent medicines. But even as importantly, at the same point, and for example, in this same remdesivir example, you take that same technology transfer to the regulator so that they can effectively be able to effectively inspect, approve that medication, and once approved, ensure that the medication circulating in the environment is as expected, not substandard, not falsified, or even counterfeits. And of course, those skills can then be carried forward onto other medicines. There's nothing unique about remdesivir when it comes to the process to approve, to ensure quality, and to ensure the product supply. And all of this hinges on the philosophy at USP we have, which I don't think is anything anyone in the room would counter, which is that there's no such thing as access without quality. And that we would assert further that there's an insidious negative aspect to poor quality as I guess an excuse for access that creates a downward spiral, because it disincentivizes basic quality. And the truth is that it's not more expensive to produce quality medicines. It's more expensive. It's cheap to produce counterfeits. That's true. But quality medicines are not more expensive because once you have your systems in place, you're actually able to produce at a very high volume with low waste, and it's just been proven over and over. However, there's a hurdle to get there. And that brings up the third that you talked about, which is quality at a global scale. And there's an upward spiral. So talk about the pessimistic view, now the optimistic view. Once quality is in the system, whether it be for a specific therapeutic that was supported, perhaps with donor funding, or just in the normal course of every day, that quality product now has an opportunity, not just for production, let's say in a local environment. The remdesivir example was Bangladesh, for example. That same manufacturer then began and has begun to apply for export licenses. And once that occurs, it creates an economic incentive. So healthy organs, a healthy drug manufacturer is able to hire local people. But in addition, that further incentivizes the quality. Now they have a commitment to another regulatory firm who hopefully, if they've been collaborating, is that harmonization of requirements, which then creates an incentive to maintain the quality and not to come back down again once in the marketplace. And that's what we mean by sort of an upward lift for quality. And that's why you can get quality and access, because that upward lift creates higher volume of quality medicines, which actually reduces the price even further. But you have to start somewhere. And we think with the chicken or the egg issue, you start with quality. At least that's our philosophy at USP. And the last thing maybe I can just mention, because I want to give credit where credit is due. Much of the work we've done when it comes to technology transfer and the production of essential medicines, both for support to manufacture and the regulator, is in a partnership with USAID. Program is called the PQM Plus for those who are interested to look that up. And we're really proud of that work. It's a continuation of over 30 years now of collaboration over 3 sister programs, and that work very much continues. So thank you so much, Maulik.
So Ron, taking on to that, I think so when you talk about low and middle income country and the producers in low and middle income country, I think so the debate that goes is the cost of quality in terms of processes, that whether we should be focusing on the quality of product or we should be focusing on the quality at each process steps, which results into quality of product. And I think so. A process approached based quality assurance is expensive versus final production of quality product. So how do we kind of address those kind of things when manufacturers in lower and middle income countries are already struggling with kind of capital availability, and then this cost versus quality conundrum gets playing its role?
Yeah, so two aspects. The first is that there is a cost to establish the quality system. And I differentiate that from the cost to maintain the quality system is quite low. So once you've achieved it, you're able to produce competitively over a long period of time. But there is an upfront investment that isn't necessary. If you don't have a quality system, then of course it's for free. You're able to then start your production. The second piece is honestly, our experience is that it's not one or the other. And there is some talk to say, well, we should get away from thinking about the product itself and talk about the process, but there's no world where that's entirely true, where you just hope the product is good because your process is good. And there's clearly a very, very poor system that only measures the output regardless of how you get there, because that has no assurance that the next product will be of good quality just because it was before. And therefore it's both. And so the value of recognizing that it's both is that you create an assurance that both the manufacturer and the regulatory authority have similar expectations. And I know this sounds boring, but this is where standards come in. And that's, of course, USP's lifeblood. A standard that both sides trust is the beginning. And without it, you don't have assurance that what you've created in your system will be accepted. And so, Maulik, the simple example, we did a study mostly with Indian generic manufacturers, but not exclusively. And we asked a series of questions about life with or without a standard. And essentially, a standard is one step towards harmonization. And we asked very practical questions. It was about access and affordability. And the results were, and I forget which order, on both time to market for a drug and cost to develop and get approved the drug. One was 30%, one was 40% reduced with the existence of a standard versus without. So that's essentially the value of harmonization. Of course, you can flip it and say the cost of not having it is quite a premium. And so yes, the investment's there, but if good standards are in place, everybody knows what the target is and they're aiming at the same thing, and their costs come down and speed goes up. It seems inevitable, but with the fact that we were able to quantitate that through a discussion with industry was really helpful to us to then show that even though there is a cost up front, it's measurable, it's manageable, and over a period of time, it actually becomes very small once you achieve that quality system.
Thanks, Ron. I think I'm hearing both from Harish and you of tech transfer and embedding quality as one of the indicator right from the word go, which becomes easier for regulator to kind of look into it when the approval process goes on. But I think so when we start talking about access to this innovative product in low and middle income country, I think so a lot of things also rely upon how stronger the supply chains exist to kind of get those products which are available in high income country or to kind of low and middle income country. And at that time, I think so global supply chain and global financing plays a very significant role. So may I come, Paul, to you? I think so based on your experience in Gavi and Global Fund, which has been instrumental in kind of making vaccines and other commodities accessible to low and middle income country. When such disruptions come like pandemic or COVID disruption for COVID or even economic disruption earlier, how do supply chain behave and how can we make the supply chain more resilient so that we are able to kind of absorb this shock more than we are? I know you have a short presentation, Paul, so do you want me to kind of relay those presentation or do you want to just be an extemporary? Yeah, the presentation is there.
All right. Would it be possible to share from my side?
If you want, yes, please do that.
Okay, if I could just, if you could ask the host to enable my screen sharing.
Yeah, please enable your screen share.
And while you do that, just again, as with the others, thank you very much for inviting me. And unlike Ron, who's sitting in the dark at 5 a.m. in Washington, D.C., I'm in sunny Thailand at 5 p.m. So Ron, I think I got a slightly better deal than you, but shows your commitment. Okay. All right.
Paul, you have the sharing rights?
Okay, let me see. Yep, I do. Thank you.
It's visible.
Yeah.
Yeah.
I hope this would work because I think it might switch screens. Let's see what happens. Is that okay? Can you see clearly?
Yeah, we
okay,
can.
Great.
Thank you.
All right. So just a quick background. So the areas of work that we've been doing in supply chain capacity building, it's, as you mentioned, health commodities. So it's not just medicines, but medical devices, diagnostics equipment, everything else as well. And not just regular supply chain, health supply chain, but pandemic supply chains as well. So just picking up on what you said, health commodities being a critical component, and I know we have this as the last overall session, and to emphasize that often health budgets and commodity budgets can be anywhere from 20 to 40% of a national budget, and often with very long supply chains. So obviously it's going from global, national, all the way to local, and we're really looking at global policies, global products, and at the end, we're looking at patient. We need to be able to reach the patient, and there are a tremendous number of steps and challenges, some of them already highlighted by the other speakers. So if we think of the 3 Ps, policies, products, and people, that keep changing, and to give you a sense from a global point of view, and that's what, when you look at USAID, Global Fund, Gavi, and any of these organizations, that are addressing these challenges at the global level. Policies, SOPs, manuals are changing on a regular basis. The products in many countries, some countries have as many as 40, 50,000 registered products. And there's always the hope that we can continue to rationalize, but even WHO and UNICEF have 10 different essential medicines lists or commodities lists or diagnostic lists. So there's a lot of products, SKUs that we are working with, and national organizations, which include regulatory, include ministries of health, central medical stores, pharmacy councils. They're usually overwhelmed, and the pace of change is accelerating. So this is a massive, massive challenge. And when you look at number of health workers that you need to work with, and we're not just talking about pharmacists or logisticians, the nurses, the frontline workers, who handle all the products before it gets to the patient. We are looking at, a small country like Ghana with 30 million people has 150,000 staff, health workers, government staff. India has several million, 3 to 4 million health staff, depending on how many we include. So large number of that, okay? And the capacity of human resources versus availability versus effectiveness, there's a massive gap. And we really have to find ways of overcoming, especially in the areas of supply chain. So when we try and think of creating a successful supply chain and a resilient supply chain, we've brought together 4 of the key categories and components: efficient, cost-effective, and self-sustainable supply chains. Availability of quality assured medicines, this was highlighted by both the other speakers, and at affordable prices. Leveraging advanced technology and digital learning approaches. There's a lot of new technologies that are coming in, and finding independent ways of making this happen. And if you want to create resilience in a supply chain, you really are looking at adding more suppliers. You're looking at increasing your inventory, increasing access to your critical products, and shortening your supply chain. Harish mentioned earlier, we're looking at local manufacturing, local production, and that's one of the reasons why this has come up. And when we talk of resilience, there is the downside. You will have increased cost, you will have increased complexity, and you'll have increased expiration of products as well, because you need to keep them on hand. The benefits, of course, you respond better to shocks, you reduce morbidity, mortality, fewer disruptions. What's interesting when you look at the global comparison of countries' supply chain efficiency, and World Bank did this analysis, it's comprehensive, more than 150 countries, looked at 6 different parameters, and this is overall logistics and supply chain, not health. And it's, they came up, sorry, just to mention, so logistics and supply chain is a $4.3 trillion industry, the health being a subcomponent of that, but it's massive. It's one of the largest industries. And the latest study they have, unfortunately, is a bit old and it's pre-pandemic. It'll be interesting to see post-pandemic what the ranking looks like. But if you look at the top 20 supply chain countries in terms of efficiency of supply chain, you have countries like Germany, Sweden, Belgium, Austria, Japan, small to medium countries right on top. I know this is a regional workshop, so I've added some countries that have been invited. Thailand ranks 32, not too far off from the top 20. India ranked 44. Indonesia 46, Sri Lanka 94, and Bangladesh 100. And this quote from the Department of Promotion of Industry and Trade by the Secretary Anurag Jain, it's a very powerful message where the government is aiming to trim India's elevated logistics costs from 13 to 14% of GDP down to 5 to 6%. Bring in efficiency, understand where the bottlenecks are, look at the challenges and see how we can overcome that. But inherent in that, and that's why many countries ran into trouble when we pre-pandemic, is we focused on efficiencies and cost at the price of having a more resilient system, the points that I had mentioned earlier. So yes, we can definitely bring down the cost of logistics, especially in a country like India that's looking for efficiencies, but we need to balance efficiency with resilience. You asked about what some of the global donors are doing in this areas of supply chain and what they are focused on. This is Global Fund's supply chain vision. If you would just focus on the black and white text at the center, it talks about strengthen and accelerate the development of efficient, agile, people-centric, and sustainable national health systems. And again, they also it continues to say that to ensure equitable access to quality assured and affordable health products. Again, you'll hear the same language again and again, and that's really the holy grail which we're trying to achieve: affordable, quality assured products equitably. If you look at Gavi's focus, and starting with the vision, the statement at the bottom, strong supply chains enable delivery of life-saving vaccines to every person when needed, no matter where they are. And if you go to the blue box, what they focus on, if you look at the key components of how they are planning to strengthen and build resilient systems, they talk about data, visibility, and use. Do we know what's going on at the front lines? And that is incredibly important because when we think supply chain, we're often thinking, supply chain organization, central medical stores, warehouses. We often neglect the nurses, the frontline workers who are in the primary healthcare organizations that are collecting consumption data and also have access to quality issues and pharmacovigilance and safety issues. And that really needs to be brought in. Strategic planning, the optimization and segmentation, capacity development and professionalization, massive gap, fundamental infrastructure and smart integration and harmonization. Again, we heard about harmonization as well. These are just a couple of examples, there's a lot more. Now, related to that, when we talk about supply chain maturity, it's a term that's often used. The literature, and if you look at the text, several organizations have developed different maturity models to understand what how the supply chain is doing and how it's progressing over a period of time. The Gates Foundation, Gavi, Global Fund, UNICEF, USA, WHO, and UNICEF, they all have different tools, but often for different purposes. But it does create some confusion at the country level. It gives options and it creates confusion. So it's really important that the countries are aware of this as well. And there is some analysis that has been done that shows if you want something that's more qualitative, quick and easy, and to give you an overall sense, you could use the Gavi, Gates, or the UNICEF scoreboard. If you want something more detailed, more that gives you more information, but usually takes several weeks, you could use slightly different ones. So you could pick from that. This is an example of global funds. Maturity model, the way they've structured it, it's also excellent. And there's a lot of commonality with the other supply chain maturity models. And it goes from canvas to bronze to silver to gold, gold being the best. And they have 20 categories of measurements. And you can see them moving clockwise all the way from efficiency of import process, ending with financial flow and control, something that you had highlighted. And within each of these, visually, it gives you a sense which components and how much is, let's say, gold, how much is silver, how much is bronze or canvas, and where they are. And which areas would then we should be focusing on for that, not necessarily for the country, but even, so if you look at the way USAID has done it, they've broken it up for health centers or hospitals, central medical stores, or the Ministry of Health. So you can apply it not only to a country, but several different organizations within a country as well. And again, what this really helps us do and understand is which areas are they struggling with and which areas are improving over a period of time. The last section about building supply chain capacity, the framework that we use is really if you're going into a country or a state or even a city, first look at the geography that you're working with. During the pandemic with WHO CRO, we worked with them to rapidly introduce WHO's tools that they needed to roll out to ministries of health, supply chain individuals, and to WHO staff. So working whether regionally or at the country level, at the state and province, and in some cases city and even the last mile. There's a whole focus on resilient cities, because if you look at a lot of these countries now, the urban population is significantly increasing. We're talking anywhere moving from 30% up to 50% now. And many of the individuals living in cities are in slums or in areas with very weak supply chain. So where is it that, so think of the target geography. Think of your target beneficiary and be comprehensive. Pharmacists, nurses, regulators, doctors, frontline workers. Target organization. Don't just think of the supply chain organizations. Bring in regulatory, bring in Ministry of Health, bring in the Pharmacy Council. There's it's sometimes, in most cases, capacity building and focus is on one or two of these organizations, but they really need to come together jointly for us to be able to help build resilience. And then think of it from a hierarchy point of view. The directors and the senior leaders need a totally different kind of capacity building versus, let's say, the technical staff. I'd referred to this earlier, efficiency versus resilience. We must make sure that we understand that we're really looking for a trade-off, right? A balance between the two, between efficiency and resilience, and not overarching in the other ones. And the last slide is an example of what we did with the Global Fund, building their capacity. The focus was really bringing the Ministry of Health, the regulatory authority, the supply chain organization, the local governments, take it down to the cities and to the front lines, and the Ministry of Health as well. So thinking more comprehensively. That's what I have for now, and if there's anything else, happy to respond. Thank you.
Thanks, Paul, for taking through the comprehensive view of when we talk about strengthening supply chain or making supply chain more resilient. You did mention about the maturity of supply chain. Now, would a mature supply chain would be resilient? Does it infer that? Or for resilience and maturity are two different perspectives that we should be looking in context of supply chain?
Yeah, excellent question, Maulik. Pre-pandemic, it would be a different definition. The focus was more on efficiency. It was on cost cutting. It was making sure that we can get the products there quickly. And the focus was also having fewer suppliers and lower cost. So if I want a lower cost product, I will not be thinking about local manufacturing and short supply chains. I'm thinking getting the products from large producers out of India, China, and other such countries. Post-pandemic, the focus has indeed been, and they've added components and line items. Maturity must include a mature system. As you move towards maturity, towards gold, you must have the ability to withstand shock in order to be able to be more resilient.
Thanks. Well, we'll come back to you later, but let me shift to Deepanwita, and I think so. This is also a shift from a global kind of architecture to kind of something which is localized and national. Deepanwita has been kind of a focal point and CEO of managing this innovation cluster, which has got more than 200. Yeah, in Genome Valley, about 200 companies, right? And I think so. When we talk about resilient system, I think so. We heard in initial kind of comments also local kind of manufacturing, local innovation, right? What is your experience of bringing this ecosystem together in kind of making sure that right from innovation to production level, there is harmonization of efforts and we are able to kind of stir local manufacturing capacity? And how do you think we can measure those things in the context of resilient supply chain?
Yeah, thank you. So, Maulik, I have to say that it was such a beautiful presentation. And, I just wanted to add before I talk about Genome Valley and what we do. Today, about 15%, he mentioned 13 to 14. My estimate, what I have seen data is about 15%. To bring it down to 10% would actually be a fantastic thing that we can. I think we have to really plan even 10%. 5 to 6% is brilliant. That's very aspirational. But I would think even 10% would be a fantastic result. Coming back to IKP, we are a research park and incubator in Hyderabad. The cluster that it's a micro cluster. Hyderabad is a city cluster. And within that, this area is called Genome Valley, where a large number of pharmaceutical, biotech, and life sciences companies are there. So the question of what is the difference that we make as a cluster or a city as a whole. So if you ask me as an enabler, during COVID, the first thing, including USP, and Ron is here, so their research center is there. So the first thing I remember is all the companies calling me saying, Deepanwita, we can't afford to close down even for a day. We want an emergency pass. Pharmaceutical industry has to be treated as an emergency service. So we spoke to the authorities, the police commissioner, and it was done. We were closed only for one day. The park was closed when there was this first declaration of closure. That was only one day. So to make sure that the companies can do their work seamlessly is the first thing of an enabling ecosystem. Ease of doing business. It is just not ease of doing innovation. Innovation will come later. Just being able to carry out business in the days where it's the most difficult period, where even communication, travel, transportation, everything was a problem. Then the second question was, how do you actually maintain the COVID protocols and work so that your systems are not disturbed? It was all together. All the companies came together within IKP, and there were larger communities that were formed within Hyderabad and elsewhere, where we decided what these protocols should be. There were a lot of global learnings. I remember in the park, first we asked KV Surendranath from USP and from DuPont, what are the processes they're following? And all the companies started, let's adopt these policies so that all the companies were open 3 shifts. How do you make sure none of these very few companies within IKP was working before pandemic, even 2 shifts. And suddenly they decided to work 2 shifts and 3 shifts so that people could, how many people will work from home? All these protocols were set up so fast because we believe that things have to be done together. What is important is pandemic is over. Is it business as usual? Do we go back? What are the learnings and what are the things we need to do together? So 4 things that IKP has adopted, and along with the government of Telangana and Hyderabad. One is to look at responsive regulatory processes. So we've formed a regulatory forum with ex-DCGIs and including somebody from USP Hyderabad. And so we really need to see that regulators understand new technologies, and they are able to respond. They say, we are not in sync with what is happening. So our attempt is to first to see that the regulators talk to the industry and the startups. They don't understand startups because regulation follows innovation. And how do we make that path? The second is, and the Department of Biotechnology and BIRAC has helped us along with the World Bank grant, which is setting up a regional TTO office, a tech transfer office, which is regional, like for entire Hyderabad, Andhra Pradesh, Telangana, and West Bengal, Bihar, Jharkhand. And there are 7 TTOs, regional TTOs like this that has been set up in India. So because tech transfer was actually a weak link. So how do we make tech transfer much more robust? The third thing we are trying to put up is evidence lab. How do we start building evidences on the technologies that get developed or the technologies that exist? So that for consumers, even for an SPO2 meter, nobody understood which one is right, which one is giving. How do you actually standardize? Who tells us which ones are right? So it is not stepping into the shoes of the regulator, but being able to come up with documents that help regulators, investors, and consumers to take decisions, informed decisions. So that's the third one. And the fourth one is a fund. So we actually, on the 31st of March 2020, we launched a fund called ICO Fund, IKP COVID Fund, and we worked with industry to put together, BIRAC put in money. We funded 25 technologies to see that these technologies, various kinds of technologies. What we also helped is to let companies pivot. How would startups pivot to make goods and services which are appropriate for the COVID times? What would the companies that do not want to pivot do, the startups? Do they close down? So Hyderabad started a program called RIGIG. So you actually mentor startups to say, okay, there are other ways of actually doing business. So how do you actually so complete turn of their business plans. So that, and we worked with about 120 startups in Hyderabad to rejig their business plans. So there are a lot of things that city as a whole can do and cluster. That's why for innovation, I think cluster is the unit. So your question was, how do you measure resilience? One is number of days it's closed. If it's number of people who lost jobs, it's easy to measure. How many new startups came in during that time? How many startups closed down? What is the revenues, the industry? City, difficult to measure, but we know which companies are there. Pharmaceutical companies, biotech companies, the revenues, we can, at least the limited companies, the data is available. Even otherwise, we know how they are figuring. So I think it is possible to track, but what, I can come back again, but what is important to see, how do we actually provide collaboration? I think collaboration is synonymous to making a system resilient. How do we incentivize? We are incentivizing production by production-linked incentives, PLIs. Research-linked incentives are coming up. Is there collaboration-linked incentives? Academia, industry collaboration, and institution organization collaboration. Will that actually affect our KPIs? Our individual organization KPIs, how would that change with collaboration? Our KPIs don't reflect collaboration. External collaboration, internal SBU collaborations, it's okay, but external collaborations, how do we put that together? Who's going to incentivize? So there are some questions about collaboration that I have, but we can take it later. Thank you.
With your understanding, and I think so, a lot of debate currently is strengthening the manufacturing capacity at a local level, right?
Yeah.
What kind of learning this IKP can go to global community, that if you want to strengthen, or even at a state level, not in our country, not all states are at the same level as far as trying or creating this kind of clusters as hubs. So what kind of learning that IKP can give to kind of, let's say G20 for that matter, that if you want to do something, develop kind of a knowledge cluster in sub-Saharan Africa, this is what you need to do.
Yeah.
Apart from collaboration.
Apart from collaboration. Yeah. So 5 things. One is government, willingness of the government to do what they have to do. For example, infrastructure, policy, enabling policy is extremely important. We need an anchor company or an anchor industry. We have to see why the region is selected for the particular purpose that we want to promote. There has to be a catalyst. There has to be a good research institute. Without that, it's very difficult to promote innovation. If you're talking of manufacturing, local manufacturing, more than academia, I think we need to look at a local, either we form an anchor, we get an anchor in that region if we want to, otherwise there has to be an anchor. For Hyderabad, we are very lucky. There's Dr. Reddy's laboratories. There is, of course, there are several others in biotech, Shanta Biotech, Bharat Biotech, and so many others. We really need anchors. Without anchors, academia is needed not only for research but also talent. And I think both these elements are very important.
Thank you very much.
Thanks.
Let me come to kind of Neeraj, I think. So we are talking about innovation, product is being there. It's quality tested. We have got local manufacturing capacity, supply chain capacity needs to be built. But when we start talking about public health system and bringing those innovation at the scale that we did during COVID, it's a different ball game, right? From your experience, and path has been kind of, and as the name said, right, getting innovative technologies to a health system. How do you kind of prioritize and how do you measure that those things are really reaching to the people, and what kind of resilient measurement indicators we can put in or structures we can put in that innovative technology gets into public health system? Because in market, it's a different ball game. In a public health system, which is generally termed as inefficient, and people may shoot down by using that word, but inefficient, in those states, what are your experience of commodities reaching to the consumer?
Thanks, Maulik, and thank you for having me here. Firstly, as I was sitting here, I was thinking we should do a fireside chat. Your access, we are path. So path to access, something of that sort. I think it'll be an important one. And I also want to thank all of you. When Maulik invited me to this last session in the afternoon of the last day, I said there's going to be nobody there, so we'll be chatting with each other. So thank you for being in the audience. Really nice to have all of you here. Thank you for braving it on a Saturday afternoon. I think, Maulik, public health, firstly, can't survive by itself. Okay? There is no public health. There is always a private sector involvement. But I just want to go back. I want to zoom out a little bit and talk a little bit about, some of the conversations that are going on at the moment. While COVID has been sort of a watershed moment in terms of what's happening in the health sector, but I think it's important, we've kind of divided the world into BC and not AD but AC, and we're trying to sort of look at it from the lens of COVID. I think we need to think about supply chains without COVID also. So while COVID has been a great moment for us to wake up to the fact that access is important, resilient supply chains are important, but I think we need to go beyond and say, okay, what is a resilient supply chain in a normal situation? And what would it look like in case we have another pandemic, the kind that we had for the last couple of years? Let's hope not for another 100. But, so I think we still need to go back to the basic and say, okay, what is it that we need to do? What do we learn from COVID? And a lot of things worked during COVID. If I think about vaccines, for example, a lot worked, some didn't. There was vaccine nationalism. So by putting one paintbrush and saying local manufacturing, I don't see a vaccine factory in Bhutan producing rotavirus vaccines, okay? Or even in Nepal probably. But somewhere, we've got to balance that out. Drugs, India's, you're leading pretty much the world on the whole drug side. But again, that too, you can't have factories all over the place. So the supply chain will always be global. I think coming finally on diagnostics, the kind of work that people like Deepanwita and Tasleem did from CCAM. I mean, I don't know if you guys are aware, but an RT-PCR test now in India costs about 300 rupees. And by the way, Eric Rockefeller was behind all of that, right? You know that. It costs 300 rupees. I was in Myanmar 3-4 weeks ago, and I paid approximately almost like $70 for a test in Burma, all right? Which means that we haven't actually been able to take this out to even countries where it's absolutely required. So there is a lot of regionalism, I think, that we need to think about. How do we set up regional centers which are going to support the public health system, which are going to support low resource settings, not just be limited to India. India is an anomaly. We are ahead of the curve. We have large vaccine manufacturing, we have large pharma manufacturing. I mean, even oxygen. I know we talk a lot about that as an, well, I'm presuming all of you now agree that it is an essential medicine. But a lot of work has been done already in India around that. How is that actually getting regionalized is one question. How are we looking at South-South collaboration on the whole public health piece? So, coming back to your question, I think it's got to be a global supply chain. We have to make resilience work, probably through regional centers. And I can tell you that a lot of conversations that are happening at the moment on the G20 health track are around South-South collaboration. It came from Indonesia to India, next is Brazil, and then South Africa. So we are all in the South now. And probably that's an important one to actually work on at this point, because the challenges of the North and the challenges of the South are fairly different. But when you look at the South countries, it's a lot of common challenges and a lot of work that we could do together. The vaccine piece, there's a huge amount of work happening in Africa, for example, trying to look at how we're going to make Africa, have vaccine manufacturing in the continent, which by 2040, they want 70-80% of the vaccines to be locally made. How are they going to get there? India has done it, right, with 60% of the world's production. So that's an important one. I think, talking about public health systems, how do you make them more resilient? Definitely, I think there's a very, very important role that the private sector can play. I go into all these meetings in the Ministry of Health, and they ask a very simple question. If Amazon can do it, why can't we? Right? Good question, right? Yeah. I don't have the answer. I think we should bring Amazon in. I think they need to be on the table. They need to tell us how they're doing it.
They did not come in.
Next time. But, I can tell you, we're talking to Tata 1mg, for example, because we're saying, okay, we've done it with the consulting firms. We as a public health organization have tried. I know Paul must be looking at me and cursing me. He said, you never called me. But Paul, yes, we're still on the public health side of it. How is the private sector doing it? How do we learn from them and build that? Because that's going to be absolutely critical for us as we move forward. Even on vaccine research, and Harish talked about it, I think it's an important piece that there's this large conversation that's going on at the moment, which is about vaccine research collaborative. I mean, CEPI has done some work around it, but a vaccine research collaborative, if we can get all the G20 countries on board to do that, and to build some sort of a connect there. Loose connect it may be, but some sort of a connect which they start sharing information, they start talking to each other. I think that's going to create a lot of resilience, at least from a vaccine perspective. I think I just want to add, so Harish talked about the bat. I don't know if it was the bat or the factory in Wuhan or the pangolin. I mean, we were still trying to figure that one out. Harish, sorry about that. But the point that he made was very important. Where is our surveillance system? And that's going to be critical. And I think that there we need to do a lot of work. How do we build our surveillance so that when there is an outbreak, when there is something happening, when we're finding some information from any corner of the country, and we're a large country, We have quite a lot of people. So we really need to get our surveillance systems going, and not only for India, but across the world, because borders are open. I don't know if any of you have been traveling recently. It's impossible. You know, all the airports are jam-packed, flights are packed, everybody is traveling. You know, so I think that's going to be extremely important. You know, Deepanwita said something, collaboration is critical for resilience. Deepanwita, I couldn't agree more. And we just don't collaborate. We just don't talk to each other. I haven't met you in like 1 year, Deepanwita. You know, this is not okay. We need to talk to each other. We need to know it. And it's not your fault. It could be mine. But, you know, we haven't met. We haven't talked to each other. So I think that collaboration is going to be absolutely critical also going forward. Just to drive down the point, it cannot be local. It is not a local thing. It will have to, of course, local will be important, but we have to zoom out and think of the world as one, think of how you want to set up the regions, how we make sure that when nationalism does hit, and nationalism will hit, the next pandemic, again, you will have nationalism. I mean, if you go and talk to the Ministry of Health in Nepal, they hate us. They hate the Indians because their entire COVID vaccination program shut down because we refused to give them vaccines. Now, why did we refuse to give them vaccines? Because we had to worry about our own people first. Nothing wrong with both sides, right? But that's what happened. So, you know, some amount, I mean, COVAX tried to fix that, but wasn't all perfect, you know, and we all know that. So I'll stop there. Sorry, lots of different thoughts flying all over the place.
No, but I think so, Neeraj, you did mention about Amazon, right? Parth did a fantastic job of trying post office, right? And do you think there is a cost factor in having a publicly, a supply chain in a form of post office versus Amazon or something? Do you think there was, from an experience, any cost differential as well as making sure that products reach to the last mile?
I don't think so. You know, I think it's when you start talking about scale and efficiency, the cost just vanishes. I mean, I sit online and I order something from Amazon, and 5 days later they fly it in from China on one of their private planes, and I pay 120 rupees. How the hell does that work, right? That works. And it's coming from China, and they've got all these planes flying all over the place, right? So something is working there. So it's scale, it's about efficiency. Post office, frankly, if you ask me, so we did a lot of work on post office being the logistics partner for health, right? It works. Why does it work? Because the post office has nothing else to do. Nobody's writing letters anymore, right? So they've got all these assets sitting all over the country, and please, I hope nobody's going to hit me for saying that, but we have this whole infrastructure. So you're leveraging an infrastructure which has already been invested in. So it works. But is it the most efficient? Absolutely not. So I think we need to think.
I think so. You've already raised a difficult question for Nikita there, and I think so. A multinational company. And I was just talking to a colleague who was part of the public health emergency response, and there was a recent kind of vaccine manufacturers meet in Geneva, right? And you know what's going on there, right? Right from identification of SARS-2 and the way David Bloom conversation has started, right? So I think so. When we talk about resilient health system, and if we look at a global architecture, it makes a lot of sense. But when you start talking about north, south, 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 I think so that's when the differences start emerging, right? And in that context, Nikita, when I'm looking at OPPI, which is kind of, again, multinational companies, trying to, doing both, penetrate into low and middle income countries with innovative products, and also trying to enhance access of innovative products. So what is your experience in terms of how can this, and I'm categorizing this, high cost product, right? High cost innovative product available to low and middle income countries. And what do you think that multinational companies are doing or can do better in making sure that you know, in resilient system, we talk about firstly is availability of product. How can you ensure that our products are available at affordable prices in LMICs or at least at a patient level?
Yeah, very interesting question, Maulik. So one thing which I want to start with, that yes, innovation comes with the cost, because if you see, you know, the product when it goes into research and finally the product when it hits the market, you know, there's a whole lot of time and effort goes. and if you really see how the products are launched in India and compared to the prices in the world, they are already like, the quality is coming, research is coming to the country, and at the price which people can afford, right? Now, how they are doing through patient assistance program. We have tiered based pricing. And now when I say patient assistance program, it's not only financial assistance, it's also bringing the whole compliance part of it, ensuring that, diagnosis of the disease happens. So I always quote this example. Let's say India is having largest population, let's say for blindness, right? I mean, glaucoma. And 10 million glaucoma patients and only 2 million are treated, wherein the cost of therapy is less than 10 rupees for a month. Now, how do you say that? Like one side you have affordability, but the diagnosis, the awareness part, the reach to the patient, that's not there. Same, you see anemia, right? I mean, you have absolutely affordable treatment, but still you see so many anemic patients in the country. So I feel the whole industry and the other stakeholders, as ma'am said, that, the collaboration, we all have to come in a very collaborative manner and have to see to it that, the diagnosis happens, the compliance happens, and that's how the disease actually gets treated. And that's where I bring in the whole access element, Maulik, that it's not always about affordability, it's also about access. I remember I was working on Hep C for India, and that's where, my previous company was Bristol Myers, and we brought in the product, and there were like 7-8 other generics where the voluntary license was given. So what I thought, the players actually kept on fighting the same market, but somebody has to really see the epidemiology model, see what's the prevalence and incidence of the disease is, like whether I am able to reach to that patient, that this particular treatment is a cure, and you need to get treated. And this is where I think multinational pharma companies have brought an excellent patient assistance model. The second thing which I want to describe is through income segmentation. So if you see the upper class, our market is a 70% self-pay market, right? 30% is a reimbursed market. It's a very classic situation where 30% of the population is living in the 70% of the urban infrastructure. So what about that 70% population living in rural, right? So you need, for the good access, you need to also have a medical infrastructure built right at the rural level. There is a missing middle. So lower income through NHA, we all heard that, that is being taken care of, like through hospitalization and all. But what about missing middle? We do not have insurance in the country. And I think it's a high time that, so we started this conversation with the insurance folks, and we are trying to, and I was talking with you, before this panel, that we need to bring disease on the table, cardiac, diabetes, NCDs, and see to it that we have, together we bring in the solution. For how long, you can say today we are into biologics, biotherapeutics. And these treatments, we consider as expensive treatment, but the honestly thing is that we need to have somewhere this part fixed, who will pay for them. So, yeah.
But Nikita, you did mention about the tier income profile, and there is a very strong argument on differential pricing when we start. Yeah.
I did nothing on that time.
No, so coming back, I think so there is a very strong argument, a theoretical argument of differential pricing in low and middle income countries. And what are your stands, and what could be done to make sure that this concept, I think so, still at a conceptual level, and so there are still good evidence of differential pricing in certain segment, but it's not something which is widely used by MNCs for market penetration or enhanced access program. So any thoughts on those differential pricing? You talked about income segmentation in terms of access, but in payment capacity, do you think differential pricing has got something that MNCs can look at?
So Maulik, I will actually quote from my live practical example where we try to do tiered pricing again in PAP. What happens is that we put PAP basis the income. So we do income segmentation and we provide PAP like let's say 1+2 for this income and 1+3 for the third tier. But you need to have a lot of paperwork done for that, and there are a lot of discrepancies and deficiencies which people are able to bypass. So really the benefit which actually should go to that particular tier is not able to reach. So I give you a classic example. India Bull very successfully managed that you need to have right documentation for your income, then only that particular program can be extended to that particular population. But I would still say that it's a large country, we have a lot to cover. So it's not easy. That's why multinational companies haven't really gone very successful with the tiered pricing.
And do you think that a government or public ecosystem can do something to kind of enhance the process of such kind of initiatives or thought process?
They can, but first they need to come on board and they need to have an alignment around that, yes, tiered system for the country can, especially in healthcare, because we also believe that, healthcare should be affordable to everyone. So when we come from that thought process, we need to really see and have a dialogue and, and then decide whether it can be worked or not. But I mean, on the business side, if I see that definitely there are operational challenges, and if we have government coming in, I mean, that thing can be looked upon.
Thanks, Nikita. I have loads of questions, but I think so. Uma is next to me. I'm not blemishing you, with all due respect, but I think so. We've got 12 more minutes. So before I ask more questions, if there are any questions from the audience they want to pose to the panelists, if not, then I can start with my sets of questions as well. Any question? Yeah, there is a gentleman out there. Can someone give mic to him? I'll give this mic to him.
Thank you. In terms of supply chain, basically, recent past, we have been hearing from these big multinationals that with sustainability coming into picture, these guys have to look out for emissions, whether 10 trucks are moving at a one time, how much emissions they are making, whether they can reduce it to 5 trucks or 8 trucks, basically bringing in more efficiencies in terms of supply chain, so as to also meet sustainability targets. Because in India also, this BRSR thing has come, and sustainability has got added to BRR report from SEBI side. So they are already kind of working towards doing life cycle assessment, you can say, thinking about sustainability, so that this entire thing can be taken care of. Now, when they think of sustainability, what happens typically? That their cost increases. So what is, the thought is coming that with sustainability getting into picture, probably I may not be able to provide my drug at this cost to government hospitals. So this is what, the thought process. So is there any, talks about or healthcare system is preparing to basically tackle this once this entire thing's gets into, the system? And also, these companies are basically thinking that whether, the government is going to give us certain incentives for taking care of climate change.
Actually, ESG is an extremely important area that you touched upon. Without looking at ESG, you will not be profitable in the longer run, because investors are looking at ESG very seriously. So I think it is extremely important for companies to work on taking ESG approach. SEBI is only doing for 1,000 companies, and it's going to come for all companies over a period of time. So I think, and actually IKP is working with SMEs to see how processes, ESG processes can be adopted. Whether there is a price advantage it depends upon how you manage your, so you know the stage 1, stage 2, the electricity consumption and all that can be managed, and that can be actually put to use through carbon credits, and some companies will be able to, not all companies, but ultimately on an overall basis, I can give you an example of Dr. Reddy's. If you look at how they have actually managed their ESG, it's really, really good. And so there are case studies available. I'll just stop at that, I think.
I just wanted to add on in terms of, you talked to some, about the government pricing, etc. I think it's important to sort of look, I'm presuming you are trying to provide services to to the public health system? Okay, so I think it's important to look at the public health system as a not-for-profit side of your business and try and cross-subsidize. Because I think the challenge is when you're looking at the government being your customer and you making lots of money. I think that's probably a challenge. So you need to probably cross-subsidize. I think that's the direction we're going. And I know the vaccine manufacturers do that. I know the pharma manufacturers do that. So that could be a thought.
No, I think we have pretty much covered. So I would say that environmental sustainability, like in the long run, I mean, that's where the companies are going. And from OPPI companies, member companies, I can say that we are high on that. I mean, our manufacturing is less here in India, but wherever we are doing, we are going pretty high on this. And in the long run, there is no other way but to go on environmental sustainability. Yeah.
So I think so. If there are no more questions, I would request Ron. I think so. He's still with us. Ron and Professor Paul. Any closing remarks would you like to make? Ron.
Yeah, thank you. So just a thank you for this. I am really proud to be a part of the IKP. USP now has over 300 staff, starting 15 years ago, and it's a wonderful home. So special thanks to that, pandering to my fellow panelists. And with just one thought with regards to, I guess is the combination of the trade-off between resiliency and some costs. I actually think it's great that our panelists have not pretended like there's not some trade-off to that, and that there is some trade-off. I think we know if it's done well, it's not a huge trade-off. But to build resiliency creates some, I'd say some more autonomy, some local say. The example about Tibet was really good. So on the one hand, there's the theory that the global supply chain and everyone can trust, but then when things get challenging, people do make sure that local populations in any given country or area space are covered. And so there's a desire, a very reasonable desire for people to participate, countries to participate in their own drug supply chain. And I only would urge us to support that, and also realize that there's absolutely no way every country can be self-sufficient in and of themselves. And so again, it's trying to find that blend in between, where some self-sufficiency to give everyone a chance to participate in their drug supply is absolutely makes sense, but also realizing that we have to rely on each other, and creating codependencies actually can I think further strengthen resiliency. Thank you.
Thank you very much indeed, Ron. Professor Paul.
Thank you, Maulik. Thank you, everybody else. Couple of really interesting points I'd like to pick on, which were highlighted by the other panelists. And connect a few dots. For sure, India needs to grow and strengthen its own supply chain, and there's a lot of room for improvement, and we talked about that. At the same time, India is also at the cutting edge when we talk about their ability to produce biopharmaceutical products or pharmaceutical products. And the work that IKP is doing is significant in that. And they're not just working in India. I had a chance to quickly see them refer to their website. They're working across a few other countries as well. Recently, a few weeks ago, we participated in with the Africa CDC and discussions around PAVM, the Partnership for African Vaccine Manufacturing. Absolutely critical. They've decided to build resilience from an angle that their target is that by 2040, 60% of all their vaccines will be manufactured on the African continent. Today, it's 1%. Okay, so massive change. And our role and the support that we'll be providing them is in capacity building, but the kind of work that IKP is doing and setting up and what they've done in Hyderabad is exactly the kind of activity or activities that several countries across the continent would be needed. So we talked about collaboration, and Neeraj poked his elbow and said that maybe we should be reaching out enough, and whether it's us or you, we haven't met, we have not collaborated with IKP, but I think IKP has a great role to play in on the African continent, and especially during the year of the G20 presidency, where we're working very closely with the Ministry of Health on how India can have a significant footprint across other countries as well. And there's a lot that we can showcase, and this being one of them. Over from my side. Thank you.
Thanks, Paul. Any closing comments?
Nothing. I think we need to work with a One Health approach. We have not touched One Health adequately in this panel, though Harish talked of it. I think all our approaches, if it's based on a One Health, we need to build awareness on One Health. And how do you build awareness? One thing that was discussed, and I just brought it, about communities and participation, volunteering. iSpirit does fantastic volunteering work. NSS, the NSS service in India, the National it's National Services Scheme, where students work, college and students. I think we have taught them on various areas, not really volunteering on health and management of health. If NSS and Access Health can work together, because their network is fantastic. And that was something my request was. And focus on One Health, if you can do this. Thanks.
Thank you. Neeraj?
No, great panel. Thanks, Maulik, for inviting me. I think we've had quite a lot of interesting conversations. I think, for me, the core of it is that in low, middle-income countries, we are building assets. We're not doing enough with the supply chains. We need to do a lot more, because that's really what's broken, what needs to be fixed. So lots of work to be done. Collaboration, critical, across. I think we all come with our own inherent strengths. Sometimes we don't realize that, you just talked about the NSS. I mean, how do we bring this together? How do we look at a whole system approach? I think is going to be absolutely critical. So that's it. It's a tough one. It's a tough challenge.
No, quickly, I just want to summarize that, it's Vasudhaiva Kutumbakam, what our G20 motto is. That's one world family. So as you said, that it has to be with One Health. And absolutely with the collaboration, what we showed, that solidarity and the resilience that we built during COVID times. I remember, I have never worked so hard, 20 hours a day, right from civil aviation to the Department of Pharmaceuticals, industry, creating dashboards where the challenges we are facing, where everything was shut down. Practically, I got a call from Air India that, we are going to Basel, any inventory has to be picked up. So when that kind of infrastructure and communication can happen, even now, things can happen in a very collaborative fashion. So I would say that, One Health is the right thing to go about. Thanks.
Thank you. I think so. The good thing for this panel is that we are ending with this word collaborative, which is a part of our global learning collaborative health system research. And so that's a fantastic thing. And what I learned, I think so, from all the panelists, just one-liner, I won't be too long, Uma, is that collaborations, capacity building, strengthening, I think so, they are need of an hour. I think so, there are enough green shoots in the way when vaccine manufacturers are aligning at a global level, at Africa level. There are learning shoots from IKP. There are evidence on strengthening supply chain. There are evidence on patient access program. But I think so, again, the bottom line is we know things, but they are not at scale. And I think so we need to learn together and we need to scale them up so that the benefits of our learning are kind of reaching to the people who needs the most. And with that closing remark, I thank Ron and Paul to be online. Ron, thank you very much for getting up so early and being part of the panel. Thank you very much. It was a pleasure. And thank you on behalf of Rockefeller, Access International, and colleagues out here. Same to Paul in the evening, but Saturday evening. Thank you very much for with us. And thank you for Deepanwita, Neeraj, and Nitika. And Harish, I'm sure will pass on thanks to you when we meet in person. Thank you very much. Thank you very much, folks, for staying with us till 5 in the evening. And I hand it over to Uma.
And I have the pleasant task of asking Dr. Krishna Reddy to share with us what we experienced over the last 8 sessions. No easy task, but I'd like to have the felicitation for our panelists. The light colors are for the ladies, and darker colors are for the men. Thank you.
I don't want to get I'm gender. Thank you. Thank you very much.
Are you there, Maulik? Oh, wait. Get that? You fight enough with me, so let me do this to you.
Thank you.
Dr. Reddy, all yours.
Yeah, thanks, Uma. I think I don't want to take any more time for people who are in a hurry to catch their flights. But at least for me as a person, I enjoyed every session. Great learnings. So, in fact, the people have summarized the key lessons that came out of each session. So I don't want to go through them. But what I wanted to summarize was, some of the things which came out very clearly, though the session started with how do we assess health systems, their resilience, what are the tools, what are the indicators. But what came out clearly is while we have objective measurements, indices, and other things, but the narratives, the stories, the experiences, the subjectivity, that was, I think, was giving much more insights as far as what is resilient and what is not. Some of the elements, at least that struck me while listening to the whole session, is it's good that Maulik said it is ending with collaboration. Typically, why human beings are ruling the world is because of that collaboration. But only thing is we collaborate when we are threatened by something, or we collaborate when we share a purpose, I think. But we have a great purpose, that is health for all, not just people, but the plants and the animals and the planet. If that is the driving force for the collaboration, I think that is the basis for the resilience. So that is one. The second element that came is that the trusting each other. Because collaboration starts only when we trust each other. And you trust each other when you accept each other. Suppose if the private sector has a business objective, it is the DNA of private sector. If you don't accept the DNA, you cannot change the DNA. So if you accept that private sector is for this business, then all the things will fall behind, because then you leverage what is the strengths of the private sector. What is the innovative strengths? What is the agility? What is the responsiveness to the people's needs? Compared to what a public sector can do by its monolithic structure, its foundation, its strength, its ability to formulate laws that govern everyone, and impose laws. So I think there has to be this identification of whose strengths are what, and whose responsibility is what, and who is accountable for what. So I think the second element that came out for resilience was that the trust between the stakeholders and between all the actors in the vast gamut of health and social systems. The third element, I think, that came out very clearly is that apart from the collaboration and apart from the trust in the health systems, I mean, because we are always groomed around from a system perspective, provider perspective, 6 building blocks perspective, but we never looked at people as the center of the health systems. And people, I mean, we only think people need this, so we have to give this. But we never thought that people's involvement in this whole process, the people's engagement, people's participation in the governance, people's literacy to take care of their own health. So these are the elements, I think, that came out very strongly in every session, that the people's involvement and the people's engagement, people's participation cannot be taken out of the health system's building blocks. So that has to be integral to the building blocks. So that is the third element that came out of this, the whole session. The fourth thing, I mean, I think we noticed that across the sessions, I mean, that everything is linked to other. The access to commodities is linked to the services. Without commodities, you cannot link to the services. And then services are linked to the human resources. So when the systems are so complex and fragmented and working in isolation, in fact, in the first session, we articulated that the critical linkages which link these complex, fragmented social and health systems are most critical to harmonize the systems. That is the information, communication, relationships. We could not cover the other two elements of these important linkages in terms of how do we strengthen that area of communications, how do we strengthen that area of institutional mechanisms of relationships, horizontal and the vertical. So this is the fourth element, the takeaway lesson from all these sessions was that we need to strengthen these critical linkages which harmonize, I mean, just like in a human complex biological system, we need the vascular system, we need the nervous system to integrate all these cells and the elements. The same way in the social systems, we require all these connectors between all these individual elements. And we don't give importance to these elements in terms of strengthening the systems. So I think with these 4 or 5, at least the high-level learnings that at least I could articulate from these sessions. And as I mentioned in the beginning of yesterday, that this is only beginning of the learning process, the learning journey. The rivers just started. And there are so many streams joined these rivers during these last 2 days in terms of the ideas, in terms of the thoughts, in terms of the experiences, their wisdom. But the journey has to be taken forward. I mean, I think the people who are interested in each of these areas and the supply chains, there's so much criticality and so much, I mean, I was happy that a case study of IKP as an ecosystem can be replicated in other geographies. Because that is essential. I mean, nobody can just manufacture vaccines without an ecosystem. So how you nurture that ecosystem in the last 20 years. So that is a beautiful case study to be taken to the rest of the other countries. Whoever is interested, they can adopt that. And you are willing to collaborate and then pass on that wisdom. So this is the beauty of this learning collaborative is that people are willing to pass on the wisdom. I think they are not possessive about their knowledge. They are not possessive their intellectual property. I think that's the more, intellectual property belongs to the world, not to the individuals, actually. If you just deconstruct that intellectual property belongs to the world, all the problems of the world will be solved, actually. We don't have to discuss so much in terms of access to the people. So with this, I think few concluding remarks. I thank everyone for the patient listening. I think wonderful to see still people alert and crowded. So thank you all.
On behalf of Dr. Reddy, Eric Arndt from Rockefeller Foundation, Access Health International, the Rockefeller Foundation, it's a privilege to stand here at the end of 2 days to say thank you. They're two small words, they mean a lot, they convey a lot, and they can be perceived and felt in all that we tried to put together for these last 2 days with so many specialists who came forward, so many experts, so many organizations, governments, civil societies, and individuals that came to share their knowledge to contribute to their learning. And as Dr. Reddy said, it is the beginning of the next phase after the first year of the Global Learning Collaborative found its feet. Yes, today still is a reminder that we had been declared as a pandemic 2 years ago, but a reminder that we have come back together to be in a physical room after 2 years, learning more, understanding more, and trying to reach out for more. And as all good things, when they come together, there are certain things that get left on the wayside. And there are apologies that need to be said for people that were not looked after or expectations that were not met, tempers that were frayed, or otherwise, certain things that we had no control over, and some that we could not have imagined. So while we say thank you for everything, we also like to say we will try to do better if there was something that didn't meet the expectations. Please do reach back to us. Please do use the poll. Please do share your experiences. Please do share, especially those experiences where there have been difficulties or otherwise. Teams, I don't think I can stand up and recognize one of you because all of you have put up with the last 30 days of crash courses of different kinds. And it's only a privilege on behalf of everybody that I share, that I personally can say thank you to each of you on behalf of both Eric and Dr. Reddy and all of you that are present here.
I'll just say 2 words because I know we are over time here. So 4 words maybe. So I just wanted to echo Uma's remarks. Thank you for participating in the 2-day conclave, the first in-person at-scale event by the Global Learning Collaborative. I hope the first of many. For me, it was a very illuminating couple of days. I've learned a great deal as a non-expert in this field. And to see the breadth and depth of expertise from around the world and such rich discussion on so many topics, I can see many different directions the next conclave could go and so many opportunities for collaboration in the year ahead. So I do encourage you to reach out to the GLC team with interest to participate in future events or come on board as a member. Any questions, concerns, please do share them. It will only make the collaborative more effective in its work in the years ahead. And again, thank you for joining.